Welcome to our live webcast, Athlete's Elbow, Elbow Injuries in Baseball Players. How do we prevent them and fix them? Thank you for joining us. My name is Jackie and I'll be the operator for the presentation today. Before we get started, I'd like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages, and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they are received and will be addressed at the end of the presentation. You will also be able to ask questions at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief evaluation summary form. Please take a moment to complete this survey as it will help Morristown Medical Center Orthopedics plan future web events and provide you with CME credits. We are joined today by our speaker, Dr. Anthony J. Scillia. At this time, I'd like to turn the microphone over to Dr. Scillia.
Great. Thank you very much to Dr. Wittig and Atlantic for having me give a talk. Also want to thank everyone at Atlantic, leadership, and doctors and nurses for getting through and managing very, very well this pandemic. So hopefully this will get everyone's mind off of things, talk about the athlete's elbow, elbow injuries in baseball players, which also does translate to overhead athletes in general, such as tennis, javelin, and as well as gymnastics. As we go, you can type in some questions, and I'll try to answer them as we go, and then we'll have time at the end of the presentation as well to go through questions. Disclosures: paid consultant for MyTech, and I've received research support from ISTO Biologics. So essentially, this slide should stick in your mind as the key pathologic forces on the overhead throwing elbow. I think the first thing you should look at in this athlete is that this position, which is a great mechanical advantage for achieving velocity in overhead throwing athletes, is really a pathologic position for the elbow. The elbow should, kind of has normal forces in this kind of plane, adduction to abduction with extension, as opposed to this abducted, externally rotated position. And so this position puts, if you think about it mechanically, it puts tensile stress on the medial side or inside of the elbow. It puts lateral compressive stress on the outside of the elbow. So you think about the bones essentially being pulled apart on the inside and being jammed together on the outside of the elbow, along with some shear stress along the back of the elbow. And we'll kind of go through that more clearly. Overuse injuries, these really all kind of fall into this overuse sports injury, which has been a hot topic in all of sports medicine. We've seen a huge rise in athlete injuries, especially in youth athletes, young athletes. We think a lot of this is due to what Dr. Andrews calls professionalization of youth athletes, which essentially means that they are able to train at a much higher level. They have much more resources, and they're essentially seeing too much of force in their elbow too early, and we'll talk about some of those differences. So with that as a background, here's showing you kind of the mechanics of that picture. If you think about that professional baseball player again, the ulnar collateral ligament on the inside of the elbow, so this is the inside of the elbow, the outside of the elbow, the back of the elbow, is where you're getting these stresses here, tensile stress here, where you get the compressive force on the outside of the elbow, and the shear stress in the back of the elbow. And we'll kind of go through each of these injuries step by step. So medial stress is your classic ulnar collateral ligament, and don't get confused with the terminology with the lateral ulnar collateral ligament, which is the other side of the elbow. So in the coding world, this is considered the MCL or medial collateral ligament, but in the sports world, we all call it the UCL or ulnar collateral ligament. So this is the inside of the elbow, the medial side of the elbow. And then these are kind of other areas along the chain that can get affected. So very commonly, the attachment point of the ulnar collateral ligament, or at least the primary portion of it, is on the medial epicondyle. So medial epicondyle stress reactions, stress fractures, regular fractures, growth plate fractures, that all is basically UCL equivalent type injuries, and we'll go through those. The posterior shear usually manifests in a youth athlete as a stress fracture of the growth plate, and as an adult in that bone spur that we saw on the last slide. This is what we call the posterior medial olecranon osteophyte, or loose bodies that commonly occur. The lateral compressive injuries typically occurs at the capitellum, which is in the form of a cartilage and subchondral bone injury, which we commonly refer to as OCD, or osteochondral defect. So to go through UCL tears, the UCL is the primary stabilizer of the elbow. We kind of think about it as like the ACL of the elbow, essentially. There are technically three bundles. If you see here, there's, let me show you this, the anterior bundle, the transverse, and the posterior. So the anterior bundle sees stress from about 30 to 90 degrees of elbow range of motion, and this is the primary stabilizer. The posterior bundle is more important in high ranges of flexion, and the transverse bundle doesn't have as much importance in elbow stability. So if anyone's taking orthopedic sports questions, they make it a little harder, and they talk about the anterior band of the anterior bundle. So think about the most anterior portion of this ligament is really the primary stabilizer of the elbow. And there's certainly secondary stabilizers. So you can think about, just like in the knee, as the elbow flexes, or as the knee flexes about 30 degrees, that's where you're really going to isolate the ulnar collateral ligament. But in full extension, you get a lot of bony stability from the olecranon fossa in the back of the elbow and the radial head abutting into the capitellum. Then there's dynamic stabilizers to the elbow, which are really this group of flexor pronator muscles. So the golfer's elbow musculature is really a important dynamic stabilizer of the elbow. And the most common presentation of a thrower that presents with a UCL tear is forearm tightness and elbow stiffness. So that musculature over the top of the ligament is really what gets most symptomatic. Just like most patients with hip labral tears present with, they have chronic hip flexor, they keep hurting their hip flexor. Well, it's really because the labrum underneath that area, and they're getting referred pain into the hip flexor. So a lot of throwers with UCL deficiency, that flexor pronator mass is working overtime, so they get a lot of symptoms in that area. You can see schematically there's a few different ways that the ligament can tear, and most importantly, it usually tears off of the epicondyle proximally or off of the ulna distally. There's also a combination where it can, so this is, show you here with the pointer. This here is a distal tear over the ulna, or there's a specific area called the sublime tubercle of the ulna. That's that distal attachment site. Here is your proximal attachment site on the epicondyle, and then here's your mid-substance tear. And so this is important in treatment strategy. The history, as I mentioned, if you ask a thrower specifically when they feel pain, when they throw, we always ask, can they throw? If they can't throw, when do they feel the pain? And that's this late cocking, early acceleration. So when their arm is maximally abducted, externally rotated, they're getting this excessive valgus force on the elbow. It's kind of 50-50 in most studies as to if it's sudden onset or it's more of an insidious onset. However, most of these injuries are overuse injuries that we usually think about it as micro trauma to the ligament over time, which then fatigue fails, and then they ultimately get a tear in variable degrees. This milking maneuver, you can see we're simulating that maximal early acceleration, late cocking phase, maximal valgus stress on the elbow. This is the most important physical exam maneuver. The milking maneuver is a static examination where you're valgusing the elbow and the patient has pain where the examiner's thumb is, which is right distal to the epicondyle and right over the ligament. There's also another physical exam maneuver that is very sensitive and specific, and that's called the moving valgus stress test. So that's really just describing a more dynamic test where the arm is taken from more flexion through extension, simulating that throwing mechanics while maintaining valgus force in the elbow. And the most important thing to realize is that it's very hard to perceive that the elbow is truly unstable due to this examination, but simply that the patient reports a lot of pain with palpation and stress. When the ligament is fully cut, it's only makes the elbow 3 to 5 millimeters looser, so that's very hard for an examiner to perceive, although it does make the elbow unstable. So it's really pain in this position. The MRI is the most sensitive and specific imaging modality. You can see here the large tear, this black structure is the ligament attached to the ulna. You can see here the white is the torn area of the ligament where it would normally attach on the medial epicondyle, which is right here. This is an arthrogram where there's dye injected into the elbow, so you can see the dye extravasating in out of the elbow. So this kind of fluid gap is a very obvious demonstration of a tear. However, some athletes have more laxity from micro tears repetitively over time, and the chronic laxity as the ligament can partially heal may not look totally abnormal on a MRI or an MRI arthrogram in terms of being fully detached, but the ligament could be incompetent in that it is essentially slacked out. And for those, we used to use a stress x-ray, which can be traumatic for the athlete and the patients, but this dynamic ultrasound has been much more useful and is being recently further studied, essentially, as to how useful that can be in determining instability. We usually compare it to their other elbow in certain positions with different weights to see how the ligament responds to stress. Because obviously an MRI is typically a static type test. So non-surgical management is the key phrase is active rest. So these are not injuries that we would put in a cast or immobilize significantly. We allow them to range the elbow and carefully work on strengthening. However, no overhead throwing and no real valgus stressing of the elbow during the period that you're treating them conservatively. That's usually around the 3-month mark. However, the absolute minimum is 6 weeks. Anti-inflammatories can be helpful. Cryotherapy, physical therapy, and athletic training rehab is key to the treatment plan, restoring range of motion, followed by strengthening and plyometrics. The plyometric programs are usually managed by the therapist and athletic trainer, where there's progressive kind of not valgus loading of the elbow to kind of restore the dynamic musculature prior to loading it in a valgus position. So the treatment, so what do you do if somebody doesn't respond to conservative management? And partial tears treated with platelet-rich plasma has been shown in a couple of studies, and this one in particular, to have a high return to play rate at 12 weeks for patients that initially failed standard conservative management with therapy, anti-inflammatories, and cryotherapy. It's important to realize that you should not inject these with corticosteroids, as pretty much any ligament that provides important stability to the joint would cause further degeneration. You could consider intra-articular injection. However, I would just caution in overhead throwing athletes, especially someone with a UCL tear, to not use corticosteroid. However, platelet-rich plasma may be an option in these patients, although it is experimental and not fully understood. So when non-surgical treatment fails or incomplete ruptures in high-level athletes, we consider repairing the ligament. There's 2 options surgically. You can repair it or you can reconstruct it. It was previously thought that repair is not really an option, as early studies by Andrews and others showed high failure rates. However, with the improvements in technology, especially with suture anchors, especially that allow ligament to bone fixation at a much higher, stronger level than previously available, this primary repair has gotten a lot of attention. In this initial study, large majority are throwers. They had, you can see here, 4 months or so of conservative management. They were repaired mostly with suture anchors, and they had a 91% return to play at 6 months after surgery. There were some complications, but repair has been recently expanded. This is the repair by one of my mentors, Dr. Dugas, who's Dr. Andrews' junior partner, and now one of the fellowship directors there, which essentially is called, in the popular terms, Tommy John light. So you can see on this first image the tearing of the ligament off the epicondyle. This is the ligament that it's split down to fully examine the joint and undersurface tearing of the ligament. The ligament is then repaired back into the epicondyle and reinforced, which you can see here. This is basically a suture tape, which is a very strong, rigid strut that essentially allows for early stability and range of motion, essentially an internal brace to stabilize the joint and offload, take the tension off of the repair. This has gotten a lot of attention because athletes have returned to play in potentially half the time as opposed to formal reconstruction. where you're trying to get a tendon to become a ligament and revascularize. This process is much more extensive than essentially repairing the torn ligament. Now you can imagine it has to be torn off of one side or the other. It can't be a mid-substance tear, and it can't be a chronically damaged, non-viable ligament. This is the ulnar nerve that you can see dissected in through here, and we'll go through some of those symptoms. So that can be associated with the ulnar nerve with injury and with reconstruction. So to move on to reconstruction, it was first performed by Dr. Frank Jobe in '74 by Tommy John, the LA Dodgers pitcher, and there was not too much hope at this point, and that's why this procedure was designed to restore some stability. And surprisingly, the athlete had a very successful post-surgical career despite having some early issues with the reconstruction, which have been the focus of modification, which was mostly pioneered by Dr. Andrews. So surgical reconstruction is indicated for those that fail to progress with conservative treatment, wish to return to overhead throwing. Again, unless the elbow is grossly unstable, such as in a dislocation, this reconstruction, the surgery, the repair is really necessary for those that are going to continue to valgously load their elbow, as opposed to the typical hinge-type motion that's necessary for day-to-day life. The technique was modified to avoid injury to the nerve by putting the nerve subcutaneously instead of under the muscle, and instead of releasing the musculature, it was mobilized. This is the schematic that really shows what that looks like. There's a bone tunnel in the ulna here and in the epicondyle, and the graft is repaired in this kind of looped fashion. If we can play the video now, which kind of shows the surgical technique for this. This is available in a UCL book chapter that we published during fellowship. You can essentially see the surgical approach is the medial side of the elbow. The medial antebrachiocutaneous nerve, or this small nerve that you can see through here, is the, there we go. Right through here provides some sensation to the back of the elbow, which is very carefully avoided. Then this portion is dissection of the ulnar nerve to get that out of the way, plus about 25% of athletes with this issue have ulnar nerve symptoms. So again, we're freeing this up all the way from what we call the medial intermuscular septum proximally to the one of the flexor muscles, FCU, distally. And here's that sensory branch traversing the middle of the picture. There's your ulnar nerve, which really sits right over where the attachment site to the native ligament is. So once all those bands are freed up and careful hemostasis or coagulation of any bridging veins is performed, we take a little strip of this muscle septum, and that allows us to transpose the nerve, or take the nerve from the back of the elbow to the front of the elbow. Here we're mobilizing the flexor pronator muscle off of the ligament. In this case, had such a chronically damaged ligament that there was a large bony fragment that was embedded in the ligament. So for that reason, we used a little bit of larger graft in order to fix that. This is drilling of the tunnel down in the ulna, or sublime tubercle of the ulna. And we essentially make a looped graft with connecting 90-degree bone tunnels with at least a centimeter or so of bridging bone to make a solid connection point here. And you can see that the nerve is carefully protected and retracted during this portion. Then we widen the tunnel slightly in order to make the graft, especially larger graft in this case, fit through those bone tunnels. It's always very important to remove any of the bony debris with irrigation so that extra bone formation does not occur. And this is that graft. In this case, it was a gracilis graft, which is larger than the typical palmaris longus or smaller hand flexor muscle that we use. And that was because we had to accommodate for a larger defect in the ligament, so not as much tissue to work with. So you see this graft that is passed, and then we are drilling the epicondyle from distal to proximal. Is passed as close as possible to the humerus here to avoid a stress fracture. And that is one of the known complications, especially when placing a larger graft, especially athletes that are throwing very hard, over 95, 100 miles an hour. That's a lot of force on this epicondyle, so we really want to make sure that we don't weaken it at all. And again, that the nerve is protected during the entirety of this procedure. Then you're going to see that we drill a second tunnel in the epicondyle, kind of in like a lambda or Y-shaped tunnel formation to allow us to pass the graft through and around in a figure of 8 pattern. You can see we're aiming for our instrument to make a connected tunnel. They do make some commercially used guides, however, the way that we're trained at Dr. Andrews Fellowship is to put the drill in specific positions and not to use a guide. The graft is then crossed in order to pass it through the epicondyle. And tied over the top. So there's no anchors or foreign material. This is a bone tunnel fixation, which in order for this to fail, the graft or the sutures would have to pull through the bone. So this is very strong fixation. And you're adding a lot of collagen to this athlete, so you can imagine why this takes a lot longer to heal and revascularize and kind of become normal again. So here we are repairing what's left of the native ligament and suturing it into the graft that's being reduced and tensioned right now, and then it's sewn together over the top. All right, so I think we can go back to the PowerPoint slides at this point. Okay. So the outcomes. This is from Dr. Andrews' group. There's a 2-year follow-up here with about 1,000 reconstructions that had 83% return to previous level of competition. It did take about a year in this series, and now with MLB data, it seems to take even longer. So higher level athletes may take longer to get back to full return to play, like 16 months or so. This is that same data set that that was followed up at a 10-year follow-up, and you can see the same excellent return to play. It's important to note that about a third of these athletes, when they were asked, what caused their retirement from baseball, if they did retire from baseball, it was shoulder injuries. So the rehabilitation and preventing abnormal shoulder mechanics is key once we've identified someone who's at risk by having a UCL tear. You can see high satisfaction rate. So we'll quickly go through some other variations of this injury, essentially UCL equivalent injuries, which is in the youth athlete is this medial epicondyle stress, which we see all the time, unfortunately. And it can happen acutely, but usually it's this insidious onset. The numbness and tingling in the fourth and fifth ridges is related to that ulnar nerve. Now you can see from that video how intimately associated it is with ligament. Tunnel sign is essentially tapping on that nerve over the ligament and reproducing numbness or tingling in the small finger and half of the fourth digit typically, which is the ulnar nerve distribution. And tenderness over the epicondyle. You can see in these MRI images some subtle bone marrow reaction over the epicondyle. You see the normal appearing ligament. So in the youth athlete with a growth plate that's open, those tall columnar cells in the growth plate are the weak point in the chain, not the ligament itself or the ligament to bone interface, which is the weak point in the adult. Here, conservative treatment is really variable. In my my experience, it can take 3 to 6 months for these athletes to kind of get rid of that bone marrow edema. I think the MRI can lag behind, so baseball dads are always wanting you to get MRIs every 2 weeks in these athletes, so you got to really avoid utilizing MRI as a guide. It's a good MRI is typically very good for diagnosis, but is not good for following these injuries and getting an athlete back on the field. I think symptomatic treatment and monitoring is really the key. What happens if there's a fracture? So that the growth plate, there's kind of a normal gapping there that you see on the X-ray between 9 and 14 years of age. But what if it's pathologic? And that's really where MRI comes into place, which we'll show you in a second. And this is that anatomy which we've kind of seen pretty well with the surgical technique, but this is the attachment site of the UCL and the epicondyle, and if that's not that's not the weak spot with the growth plate being open, you can get damage to the growth plate. So MRI, people also utilize contralateral x-rays. I like to avoid radiation in youth athletes, so we often get the MRI. Same kind of symptomatic picture. MRI can be very helpful, and it depends on the type of patient that you're dealing with. If it's minimally displaced and it's not a throwing athlete or a gymnast, we let these heal. However, if they are an overhead throwing athlete, any real displacement can cause incompetence of the ligament, instability, and long-term issues. So we often will fix this with a screw. Of course, we make sure that we reduce it anatomically and keep the nerve out of the way. Post-operative rehab, passive range of motion initially and gradual return to play once a restoration of full strength. And once you get bony union, you can progress a throwing program. The non-union is a big problem in youth athletes. So you can see here the epicondyle was damaged, maybe not recognized, and then is unable to heal. And so trying to get this to heal back to its anatomic position is often fraught with difficulty and failure in multiple surgeries. So we have a case series where we essentially excise the epicondyle and repair the ulnar collateral ligament and flexor pronator mass back to the bone with suture anchors with excellent return to play in gymnasts, football players, as well as baseball players. Obviously not the initial treatment option, but in these difficult cases that unfortunately we see from time to time, there is a good surgical solution. Postoperative rehab is slower in those cases, and we could certainly provide people with our postoperative protocols for physical therapy rehab and our throwing program, as well as the Throwers 10 exercises. We just don't have time, unfortunately, to go through all that. So what about the back of the elbow? These olecranon apophyseal stress fractures can be problematic, especially because the growth plate, it may appear normal. However, it goes between 12 and 15. So if you see a 17-year-old or an 18-year-old baseball player that still appears to have a growth plate, that's a problem. So it affects their triceps function. They have a lot of dysfunction, pain in the back of the elbow, and it's due to this forced extension and shear across the back of the elbow. They should have tenderness in the area, weakness of the triceps, and plain radiographs that I mentioned, unless you get a comparison view, you may think is normal. So here's an example of a pitcher, 17-year-old or 18-year-old pitcher with a left, their contralateral physis is fully fused. You can see on the right side, you see this basically a non-union or a growth plate that will not close because it's seeing too much force through the triceps and the back of the elbow. And unfortunately, these can be treated non-surgically, especially if they're younger. However, they really often don't typically heal and often need surgical treatment. If they are displaced at all as well, they need fixation. You need to gain a lot of compression in the back of the elbow with the distraction force of the triceps being there. So we place quite a large screw. You would think that that is, quite a large screw for a small fracture, but you really have to gain a lot of compression in order to get this to heal with all that distraction in the back of the elbow. There's a very small case series available. They did have good return to play at 16 weeks. We're working on our case series of those as well. Lastly, we're going to go through osteochondral lesions. This is impaction on the lateral aspect of the elbow from compression. The capitellum is the most common area to get this damage, and it's the subchondral bone and cartilage that's affected. It is more common in youth athletes and gymnasts and baseball players due to loading of the radial head into the capitellum. Plain x-rays can be helpful if the subchondral bone is disrupted. You can kind of see this darker area there and some fragments, but MRI is the best test to identify it. Again, it's this compression type injury. There may be some vascular, with the posterior vascular supply, that may lead this to a higher rate of injury in this location as opposed to radial head OCDs, which we don't see as commonly. But it is, again, overuse injuries, repetitive microtrauma that we see in the lateral aspect of the elbow. So non-operative management really is reserved for those with open growth plates and with a non-displaced and not unstable lesion. So if there's any fluid or any disruption of that subchondral bone, like we can see in this picture here, with fluid behind it, that's an unstable lesion, and it needs to be treated surgically. If it's stable and their growth plates are open, there's good chance that the athlete can heal. So indications: if there's a loose body that needs to be removed, it usually causes mechanical symptoms. Failure of non-operative treatment for stable lesions, and there's a lot of different ways to approach this surgically, but this is our approach, where you can see the patient is laying on their back, and this is their elbow brought over their chest. So In order to access these lesions, this is us marking out the capitellum and the radial head, and we use these kind of 3 portals on the side of the elbow in order to access this very small area with flexion of the elbow. And so we can oftentimes address these arthroscopically, so it's less invasive, and the athlete usually has a quicker recovery. This is that piece of bone here and cartilage that needs to be removed, and this is what it looks like arthroscopically. You see this frayed edge here, the healthy appearing radial head in this position, this abnormal cartilage around and adjacent to the lesion. And here is that kind of cartilage defect as we're kind of preparing it and making it smooth. So what we do is we try to find a stable rim in order to repair it. The quote-unquote standard of care is to do a microfracture where you drill into the bone here. However, especially in weight-bearing athletes, overhead weight-bearing athletes, microfracture, as you may have seen in the knee, we've published on that, 5 times worse, return to the NFL with microfracture. So our current method is by using some bone marrow aspirate to access some stem cells, mesenchymal stem cells mixed with donated cartilage that we're allowed to get all this done arthroscopically without manipulation is allowed in the U.S. And we seal it with this fibrin glue, and we are currently still researching this, but have had excellent outcomes, and hopefully we can report that to you in the near future as we're getting some of our case series submitted. Postoperative protocol is similar: passive range of motion for 6 weeks, strengthening for the following 6 weeks, starting the throwers 10 exercises, which we can provide to anyone that would like, or it's readily available online. If you just search for this, Kevin Wilk at Andrews is one of the pioneers of this. And then after 3 months, if there's full motion or normal motion for a thrower, as they often have some flexion contracture, but once you've gotten them back to their baseline, you can initiate this throwing program and get them back to play, which usually takes about another 3 months, so they're usually in that 6 to 7 month range, getting back on the mound or back to impact, loading, vaulting, etc. with gymnastics. So to quickly run through this, we're all very concerned about the epidemic in elbow injuries and youth athlete elbow injuries in general. We have seen them rising. Just a couple key concepts as we're nearing the end here is there's a 36 times higher risk of injury in a youth athlete compared to a college or professional athlete because they break down their mechanics. So I think if one intervention that we can use is to make sure youth athletes don't play to the point that they're fatigued and are not kept in a game when they're fatigued, because they really break down their mechanics, and that leads to higher rates of injury. The other key concept I want to make sure everyone realizes that every thrower needs 4 months off from throwing per year. It doesn't need to be consecutive, but that's a 5 times higher risk of injury to the elbow when that's not followed. So they can play on multiple teams, but they can't have this consecutive, teams year-round. It's not tolerated, especially in youth athletes and those that get injuries. This misconception, which I think we've been doing a better job now, is that we're getting less and less athletes coming in that want to have Tommy John surgery. So obviously surgery is never the first option. We always use it as a last resort. It does not make the athlete throw harder, throw better. It's not the easy way to get to the next level. And revision surgery, which has become more and more common, has poor levels of return to play, especially at the professional level. This website can be very helpful for anyone who sees a lot of these athletes, and I think referring them to stopsportsinjuries.org, the Sports Medicine Society Injury Prevention Tip Sheet, is very, very helpful. A lot of common sense things we don't end up doing in practice, so I think, kind of going through each step of what the athlete does, their warm-up, positions, making sure that one coach is not doing, a great job or is doing a great job keeping track of all their guidelines and their pitch counts, but then they're playing some other team, there's no communication, so you kind of have to be the captain of the ship when dealing with these athletes. So in conclusion, thrower's elbow is really due to the pathologic position of the elbow in abduction external rotation. So that's medial stress, lateral compression, posterior shear. You need to be conscious of this. It's a little harder to deal with and a little trickier in Scillia mature athletes. And that growth plate is a little more sensitive than an adult. Mechanics are harder to control, as there's a lot more inconsistency in youth athletes. The UCL is the primary stabilizer of the elbow for valgus stress. MRI arthrogram is the best test at present to identify this injury. Conservative treatment and coordinated care is the key to successful non-surgical management. But in those athletes that really needed Tommy John surgery or Tommy John light in certain specific circumstances, do show a high rate of return to play. Education of youth athletes is really the key, and we need to all approach this seriously, as we kind of mentioned. It's a picture from fellowship with Dr. Andrews and our Big East Championship at Seton Hall, and thank you guys very much.
Dr. Scillia, can you please explain to us again how you examined the elbow?
Yes.
And how you determined and go over what valgus means?
So valgus essentially means that the position of the elbow is out in this direction and the arm is being forced backwards in this position. So that you're getting the stress on the inside of the elbow. So if Dr. Wittig was to pull my thumb this way, I would increase the stress on the elbow. That's what we call valgus stress. Their stress is in this position, which is required for day-to-day activity and normal life, but does not put any stress on the Tommy John ligament, which is why this injury is unique to athletes where they stress the inside of the elbow. If you guys have questions, just type them into the Q&A box and I can read them off. Yeah, video demonstration, we can add that to the talk, but there are a lot of these examination maneuvers online. I hope that was helpful to clarify. Would there be any benefits of testing in 0 degrees as well? So it's different than the knee, because like in the knee for an ACL or an MCL, at 0 degrees usually tells you that this is a multiligamentous injury if there's instability, as opposed to in 30 degrees of flexion. So in this case, if there was a fracture of the radial head or olecranon, you could get instability in 0 degrees, but you cannot get instability if it's an isolated ligament injury. You would need to bring the elbow to mid-flexion, 30 degrees and above. Braces have not been proven to, so the question is, are there any braces that can be preventative for valgus stress? There are certain proprietary braces that exist on the market, and to my knowledge, there's no study that shows that they're able to prevent a UCL tear. You know, I do have some athletes that utilize these. However, you know, it's not been proven to prevent it. The reality is the amount of force that you can generate, unfortunately, there's no external apparatus that's able to reduce the force there significantly to really prevent an injury. Biomechanics, injury prevention guidelines, as you mentioned, is to date the most effective method. However, if an athlete is able to perform with a brace, I doubt it hurts. Question is, do you commonly see OCD lesions on the capitellum alone or in addition to UCL issues? So that's a really great question because you know, the theory is that you shouldn't really get overload on the lateral side of the elbow if you have intact medial structure. So I guess what I'm saying is, like, if the rubber band is not slack on one side, it's hard to pinch down on the other. You know, the real world application of this is probably 90% in my practice of OCD lesions of the capitellum are isolated. We do, of course, get an MRI arthrogram, and cases where we are concerned, we will get ultrasound stress tests. However, I would say in theory that is a concern, but in reality, they typically are isolated OCD lesions of the capitellum. However, although we didn't have time to go into it too much, but the bone spur in the back of the elbow, that posterior medial olecranon osteophyte, stress fracture of the olecranon is typically associated with UCL incompetence, and most of the those that we've had to fix, we've also had to fix the UCL. Question here is, do specific types of pitches thrown at increased risk of UCL injury in our pitches encouraged to avoid certain types of pitches post-op? So in post-op, we really focus on fastball, changeup, and avoid the breaking pitches until really the athlete has a lot of confidence. So if you're talking a reconstruction, that's usually after a year. If you're talking a repair, you're talking, you know, in that 7, 8, 9 month mark. Dr. Andrews used to say you should never throw a breaking pitch until you can shave. I mean, that's not a, you know, I can tell you that there's a lot of scientific evidence behind it. What I can say is that the curveball is not thought to be as associated with higher risk of injury, but you know, slider is. But I think statistically and literature is not, to my knowledge, have proven this. I think the reality is when you're rehabbing an athlete and when you have a youth athlete, you really want them to focus on fastball, changeup, and leave the breaking pitches until later on in their career. Casey's asking, do you think overpitching or shoulder weakness contribute to an increased risk of UCL injuries, or do you think most patients have some combination of both factors? I think that's the reality. I think the most common scenario is some sort of biomechanical abnormality, which puts you at higher risk of injury of a UCL tear. But the reality is the abnormal force that really any athlete can generate on the medial side of the elbow, if not protected by secondary stabilizers and really good technique, in one throw, one time, you could tear your UCL. That ligament is not strong enough to withstand normal forces, even in youth athletes. So same kind of thing. I hate to keep going back to the ACL, but if you let somebody back too quick and they don't have quad function, and you know they cut, and even though the UCL reconstruction is stronger than the native ACL, they could re-tear that easily. with the amount of rotational force you can generate. Yeah, so I think physical therapy, identifying weakness, identifying deficiencies is the key to injury prevention and to successful rehab. Demetrios is asking, is throwing greater than 50% fastballs in the MLB still seen as predictor of UCL injury? That's a good question. I'm not aware that that is correct, but I'll definitely look into that. All right. Any other questions? All right. Well, thank you to everyone for having me. Thank you everybody for joining. I'll look up a couple things for you guys, and we'll see if we can get them out to you. And stay safe out there. Thanks.
Thank you so much, Dr. Scillia. On behalf of Morristown Medical Center Orthopedics, I'd like to thank you for your participation in today's event. A post-event evaluation summary form will appear requesting your feedback. Please take a moment to complete this survey, as it will help Morristown Medical Center Orthopedics plan future web events and provide you with CME credits. This concludes today's program. Thank you and have a great day.